So, very good morning to all the viewers of the SICOT India Scholar Program and SICOT India. On behalf of SICOT India, I welcome you all to this new year with a new series on pain management in orthopedics. Today we have with us Dr. Bhavin Jankharia, who is a well-known musculoskeletal radiologist in the city of Mumbai, with a keen interest in interventional radiology for various musculoskeletal problems. He is going to be speaking to us about radiofrequency ablation in various orthopedic lesions. Welcome, sir.
All right. So thanks, Swapnil, and it's great to give this lecture on behalf of SICOT India. And I'm going to be speaking on radiofrequency ablation, predominantly focusing on osteoid osteoma, but will also essentially be looking at other entities as well. So when we look at all of these, we basically talk about radiofrequency ablation as the way in which we would treat osteoid osteoma, osteoblastoma, and chondroblastoma. When we start with osteoid osteomas, and that's going to be the focus for the next 10 to 12 minutes, I think it's important to understand that the diagnosis itself can be such a challenge in many instances. For example, this 15-year-old boy with pain had pain in the right hip joint, and it took 18 months before somebody recognized that there was an area of sclerosis here along the medial femoral cortex. Then the MRI showed the focal lesion here with the central low signal dot, and the CT scan confirmed the diagnosis. It gets even worse in the spine. You can see this patient with non-specific marrow edema involving the L1 spinous process. As often happens, the patient was put on AKT, didn't work. 2 years later, the patient came to us. We normally do a dynamic contrast study. When we give contrast, we found this focal area here, and the CT scan then showed this tiny osteoid osteoma along the inferior aspect of the inferior article of a set. So it's to have a high index of suspicion for an osteoid osteoma. Obviously, when it's so obvious like this, it's easy. The diagnosis is small, but in the femoral neck, in the spine, and many other parts of the body, it can take up to 2 to 3 years before the diagnosis gets made. Now, all patients with osteoid osteoma who come to us are evaluated for the possibility of radiofrequency ablation. And usually, only when the lesion is in the spine and close to the cord or the nerve root do we not do the RFA. Otherwise, there is no real contraindication. So we will talk about the pre-procedural, procedural, and post-procedural issues. I do all my RFAs under CT guidance. So prior to the RFA, at least a day prior, we do a detailed counseling, which involves explaining the procedure to the patient and the relatives. If the child is young, then obviously the parents. We talk about the possibility of recurrence, which traditionally is in the range of 6 to 7%, but now in our hands is about 3 to 4%. We talk about post-procedure pain, which can be quite intense in the first 2 to 3 hours. And we also discuss the alternatives, including surgery, just so that the patients are aware why they are getting an RFA done, which is often a little more expensive than doing surgery. Clearly, the INR needs to be normal. And sometimes if the child is young, has a runny nose, etc., we ask the anesthetist to evaluate in advance, but most of the times that's not required. All our studies are done using intravenous sedation. For almost 10 to 15 years, we used only one system, and that was the Rita umbrella electrode from AngioDynamics, where you see these tines here which open up into the bone. But for the last year and a half, we've also, in some instances, been using a straight needle supplied by Boston Scientific that uses the impedance method for burning osteoid osteomas. So I will talk about both techniques. They're essentially similar. but there are a few differences as well. Now, when we do an RFA, it is important, irrespective of technique, to have these dispersive pads put in, because the body is essentially then an electrode, and you need to have the heat being dampened. Otherwise, there are burns that will occur on the patient's skin. And these are all done intravenous sedation. This is the basic setup. I do this with a CT fluoroscopy, but that doesn't have to be done. You can just do it with a regular CT scan. That's the generator for the angiodynamics machine. And that's the electrode that you see here. So that's the tray that we have, a hammer. There's 11 gauge needle. We use the one from Cook. There's also another. This is a non-shielded needle. This is a shielded needle, and therefore we have to make the change, the K wire, and we use a drill. We now have a battery operated electrical drill that we use as well. So this is 11-year-old with tibial osteoblast that we wanted. So the first thing you take is 11 gauge needle and drill it into the bone. Then you put the K wire in and position this properly. Then you have to remove, for the Rita electrode, you have to remove the non-shielded needle and put in the shielded one here. Then remove the K wire and exchange it with the electrode. And then we burn it at 90 degrees for 5 minutes, sometimes 100 degrees for 4 minutes. And that's it. That's pretty much the procedure. With the Boston needle, it's actually a little simpler. Here is this patient who has an osteoblast in the diaphysis of the humerus. You can see that really well on the CT scan. And there's a small vessel here. This is called the CT vessel sign. So here we are using the 11 gauge needle to drill into the bone. And now we've done the drilling. And then all I have to do is push in the electrode directly. The electrode, since it's using impedance, it can go through a non-shielded needle as well. All we have to do is make sure that it's positioned across the osteoma, and then we would burn it. So it's a little faster process. It doesn't require exchanging of needles. However, because it uses impedance, sometimes if the bone is very, very sclerotic or thick, then the ablation may not happen. After the procedure is done, we obviously wait till the sedation wears off. This is done on an OPD basis. And so typically the patient is in the daycare in the center for about 3 to 4 hours, and then the patient is allowed to leave. We take care of post-procedure pain with intramuscular or intravenous painkillers, especially if it's significant. And that's it. We do not need to see the patient again. We call the patient up in the evening to see how they are. Again, the next day, twice morning, then one the next 3 weeks, and that's pretty much it. We do tell the patient that if they have recurrence of pain, the classic pain that they had prior to the ablation, usually there are night pains, usually these respond to salicylates and painkillers, and if these recur, then they have to call us, and then we will re-image them to see if there is recurrence or not. So let's look at a few examples. That's a standard femoral neck lesion. We would go from anterior. However, if the lesion is anterior or located in another area, we may go transthoracic as well. This is a posterior tibial cortical lesion. Many people make the mistake of taking a posterior route, which is often not recommended because you can have some nerves and vessels coming in the way. So the anterior transcortical route is far better. Now we come to a few spinal lesions, which are the ones that are challenging. This one's simple and straightforward because there's well corticated bone here. So you can see the osteoblast and we burnt it without doing anything special. Whereas this one has a deficient cortex medially, and though the ligamentum flavum is a good barrier to heat, we actually injected epidural air inside because the air then also acts as a barrier to heat to prevent any thermal damage to the nerve. The large osteoma which is hanging into the spinal canal, but it is very well corticated. So the plan was to go into the center of the lesion. So we still injected some intradural air, and then we went into the center, ablated up to about 90%, and sometimes that's enough, and this patient never came back with recurrence. Here is a composite image. We had posted this on Instagram. This patient presented with pain and marrow edema in April. Nothing was done. Then came back in October. Again, there was marrow edema. Nothing much was done. But then they came for a biopsy, at which time I realized that we were perhaps looking at an osteoblast. So we did the CT scan first, which showed this classic osteoblast in the superior articular facet. And this is very easy to ablate. And you can see that we've done this using the straight boss needle that uses the impedance technique. This was a few years ago. This is an elbow osteoblast. This patient was suffering for a long time because this lesion had been missed. All that the earlier MRIs had shown was marrow edema, so he was treated for tuberculosis, for synovitis, until we picked up this lesion. And then, of course, ablating it is easy. And here you can see the umbrella electrode that we've used here to ablate this lesion. And this is another patellar lesion that you can see here. So what are the parameters to evaluate? Often, patients will ask us, what is it that we should be doing? Should we come and see you? How do we know that the pain has gone? Well, essentially, disappearance of pain in about 24 to 48 hours is what tells us that the RFA has been successful. There is no further imaging to be done. And in fact, we dissuade the patients from getting imaging done because what often happens is that the osteoblast takes about a couple of years to disappear, and sometimes never disappears. You still see a focal area of sclerosis on CT or a little bump on MR. And another radiologist who is not conversant with post-osteoblast changes could actually give a report that says something like, there is residual disease or something, and then patients get extremely upset, and it creates a problem, right? So nevertheless, in our early days, we did image these patients, and what we found is that immediately after the ablation, this MRI was done within a couple of hours. You see the zone of ablation around the osteoblast. We did have a couple of patients coming back at that time. So this was after 10 months. You can see that the lesion is filling in, but it takes about a couple of years. And now you can imagine that if this was somebody who didn't know what happens with osteoblast, and if they reported residual disease, the parents will just get hyper. And then all you have to do is try and tell them that if the patient is pain-free, then that's all that matters. There is nothing else to be done. We can have recurrences. Typically, unless the lesion has not been ablated correctly the first time, the recurrence occurs a little to the side of the original osteoblast. So here's this lesion, we ablated it, and we had a new lesion that came up along the inferior aspect of the osteoblast, and we went and re-ablated it as well. So that's not a big deal. Unless it's a difficult osteoblast to begin with, as far as RFA is concerned, it's very easy to RFA. Complications, thermal burns and blisters. These occurred in our... We weren't very careful with our dispersive pads. But ever since then, we've not really had this as a problem. These are some blisters that occurred in another patient, but these have been sorted out as well, and we don't get them anymore. Infection, this was one patient, and we still don't know how this happened, where this was the defect and the patient landed up with some sequestrum, and this just kept going on. But this is the only case in the last 480 patients that we've ablated who's had infection. Now, RFA can be used for other benign tumors as well. Osteoblastoma is a cousin of osteoblastoma in many instances. We had biopsy proven this lesion in the rib. And then because the lesion was less than 2 centimeters in size, we used the umbrella electrode and we ablated it. And this patient does not have any recurrence. The only thing that has happened with this boy, this was done about a year and a half ago, is that he plays football and goes to the gym. And there is residual sclerosis, though we haven't re-imaged the child, and every now and then he will call in saying, I've got some pain, and this typically happens after a shoulder press or after tackling or falling down while playing football, and we have to reassure him and say that it's mechanical pain and not related to the osteoblastoma. This is a chondroblastoma, again biopsy proven. And if the chondroblastoma is less than 2 centimeters and not really in a weight bearing area, then radiofrequency ablation is an acceptable alternative. In all of these, we do need to use the umbrella electrode so that we have a large area that we can easily ablate, as we have done here. And so the general rule these days is that the chondroblastoma should be less than 2 centimeters. And if it is in a weight bearing area, we just need to be a little careful to make sure we don't burn the articular cartilage in the weight bearing area. Otherwise, you can land up with chondral collapse and osteonecrosis. But otherwise, this is another indication. And I think we've ablated about 10 or 12 chondroblastomas in the last 5 to 6 years. They are not as commonly ablated as osteoid osteomas are, but then that's the indication as well. So what we've done in the last few minutes is essentially looked at radiofrequency ablation as an option for treating osteoid osteomas, osteoblastomas, and chondroblastomas. Osteoid osteoma is the indication for radiofrequency ablation. It's been around now. I think we've been doing this for the last 15 years. And most people consider this to be the gold standard. But there are some who still do core decompression, who obviously still operate. And some people have used MR-guided focused ultrasound as well. But and while there are no head-to-head studies, because these are impossible to perform, this is really the method of choice. So thank you for your attention. And Swapnil, if you have any questions.
Thank you very much, sir. That was Dr. Bhavin Jankharia from Jankharia Imaging. He's a very well-known radiologist in the city of Mumbai and has a special interest in musculoskeletal disorders. A few questions which just come to my mind as an orthopedic surgeon. The first one is that we've had a lot of discussions on our forums regarding post-operative infection. There are some people, orthopedic surgeons, who've not really had much of a problem after their patients have undergone RFA, and some of them say that there is a very high incidence of post-procedure infection. As you mentioned in your series, there has hardly been an infection, just one patient is about 450 odd. But does literature also support this, that the infection is
extremely rare? Because in the end, it's like doing a biopsy. It's a closed system. You're introducing a needle. Through the needle, you put in an electrode. The whole thing takes about 8 to 10 minutes. It's anyway done under aseptic precautions. So the chance of infection is extremely, extremely low. I would be surprised. I mean, if you have found that, but that would be an anomaly.
Right. The second question, of course, is related to the neurovascular bundle and lesion around the spinal cord, around the nerve roots, and around nerves. How safe is radiofrequency ablation around nerve roots and around nerves in the spinal cord?
So you have to keep a gap. With the Rita, the gap is supposed to be about 1 centimeter. And the challenge with the umbrella electrode is because it requires a shielded needle. Anything along the path of the needle also, you need to make sure you're reasonably far away from the neurovascular bundle. While people have used the 10 millimeter, you can get away with 5. And in case you're worried, we can inject distilled water along the path or inject air along the path. And both of them are very good insulators. The other needle supplied by Boston, in fact, does not produce heating along the needle. It only produces heating within the bone in the osteoid osteoma. And therefore, unless your osteoid osteoma is in a situation where you have a neurovascular bundle within 0.5 centimeter, there is no problem. So the challenge obviously is in the spine, where there is, so the thing is, all of us believe that this is predominantly theoretical because we don't have reported cases of cord or nerve damage. It's possible people don't report these when they happen. But if we use air as an insulator and able to get between the osteoblast and the dural sac, then there is generally no problem. Even a millimeter of air is good enough to completely insulate. A lot of people use nerve locators. So they'll put in these electrodes to check for nerve impulses and then keep the patient, do this under conscious sedation, and then keep checking whether there is damage or not, especially the osteomas in the cervical spine that are near, stuff. So each case has to be judged independently. And we still believe that in the spine, there is a role for surgery, especially because with surgery, you know that you're not going to damage the cord or the nerve root. So if there is even the slightest possibility, it's just best to operate.
Now, coming to the last question, and this is about the cost-benefit ratio. Vis-a-vis surgery compared to radiofrequency ablation. Now, there are a lot of myths about radiofrequency ablation being, kind of a procedure which is quite expensive to a poor patient. But if you look at the cost of surgery vis-a-vis the cost of radiofrequency ablation, I personally think that the risk-benefit ratio versus the cost-benefit ratio is extremely good in a radiofrequency ablation. Your thoughts on that?
I agree with that. So yes, radiofrequency ablation, depending on what you use and how you do, the cost can range anywhere from about 75,000 to 1.5 lakh, etc. And surgery also, I mean, depending on where you operate and who operates, can have pretty much similar costs. The advantage of RFA is that the moment you do the RFA, the patient is up and running within 4 hours. And from the next day, the patient resumes their normal activities. If it's lower limb, we just tell them to avoid high impact activities for about a month. But young kids don't even follow that and nothing really happens. If it's upper limb, non-weight bearing, then there is no other precaution to be taken as well. Whereas with surgery, there are two problems. Number one, you don't even know for sure whether you've removed the osteoma. I think it starts with that. Two, there is always a recurrence rate irrespective of the method. So even with surgery, there's a 6% recurrence rate. And thirdly, it can be a major surgery. If you have a femoral neck osteoma, you're looking at significant downtime for the patient, crutches, non-weight bearing. If you just explain to the patient the costs involved with not going to school, not going to college, sometimes not going to your job, taking off, I think it just all immediately, even the poorest of patients will tell us we'd like to do an RFA rather than doing surgery. So if that option is given by the surgeon to the patient, I don't think the patient will ever opt for surgery.
Right, sir. So that is all we have. But if our audiences have any questions, please put them in the comment section and we'll pass it to Dr. Jankharia and we'll be very happy that he'll answer the questions for you.
Absolutely. And thanks, Swapnil, for the opportunity and thank you. It was fun doing this.
Thank you very much, sir.
Take care. Bye-bye.
Thank you, sir.